Okay, everybody. Well, thank you for joining us this afternoon. Today we have one of our fantastic heart failure fellows, Dr. Colby Salerno, who's going to be presenting on hypertrophic cardiomyopathy, talking about the pathophysiology, clinical presentation, risk stratification, and management. So thank you, Colby, for putting this together for us and looking forward to see what you have to share.
Thank you, Dr. Beasley. Appreciate the opportunity to talk about this topic today. As you mentioned, we're going to be kind of talking broad overview of hypertrophic cardiomyopathy, the pathophys, the clinical presentation, risk stratification, and management. So given that we're diving into a lot, I think it's for the most part, not getting into the nitty gritty, just so we can cover as much as possible today. Starting with just your general background. So it's a heterogeneous, monogenic heart disease. It's been studied now for more than 60 years, and it's been recognized to be an important cause of arrhythmic sudden death, heart failure, and AFib, with a known significant risk for embolic stroke in these patients that do have AFib. It's been seen all over the world, and in regions including USA, Europe, Japan, China, East Africa. It's established as a very common genetic heart disease with a prevalence of at least 1 in 500 in the general population. And the key thing is at least, because it's likely much more common than this, possibly as much as 1 in 200. Prognosis, however, is very favorable, especially as we've learned more and more about this and as we've risk stratified patients. But sudden cardiac death and severe congestive heart failure in a small subset of patients is still occurring. And it is known as a diagnosis of exclusion. So secondary causes of LVH, including systemic hypertension, valvular and subvalvular aortic stenosis, and infiltrative cardiomyopathies should be ruled out. A wall thickness of 15 millimeters by echo, CT, or cardiac MRI in the absence of a secondary cause is consistent with HCM. Included this slide just to kind of, again, reiterate that there is a global distribution of this disease. At the time, this was done in 2022. I'm sure we have even more countries where, over the last 3 years that this has been recognized, but it's been shown to involve 90% of the world population that we know of so far. And like I said, the prevalence is probably somewhere in the 1 in 200 to 1 in 500 range, with an estimated 15 to 20 million affected worldwide. I wanted to start with genetics. This is a known genetic dysfunction that causes this, and we're still learning about it, every year. And genetic testing has a strong role in this, in family screening, identification of phenocopies. However, one thing that's continued been looked at and has not been shown is that these sarcomere mutations do not predict sudden death prognosis or future clinical course in these individual patients. It can be inherited as a Mendelian autosomal dominant disorder with variable penetrance associated with variants in genes encoding proteins of the cardiac sarcomere involving the contractile function. With introduction of commercially available genetic testing, 11 or more genes have been identified in HCM patients. MYPBC3 and MYH7 by far the two most common, but now with greater than 2,000 individual variants, some designated as private, unique to this individual families, or others considered likely pathogenic. I included this slide because I felt like it was very interesting to take a look at how unique it can be within a single family. So here you'll see, second. All right, here, just got to move my stuff out of the way. All right. So you'll see that this family, you have a 62-year-old who has the MYPBC3 positive gene mutation, and then needed an ICD for an LV apical aneurysm at the age of 58. And here is children. You have one child that does not have the disease. You have another that's genotype positive, but completely phenotype negative and asymptomatic. And then you have another who has severe LVH seen at the age of 25. And there you're showing, here you're showing the ventricular septum and how thick it is. And then you have another patient, another child who needed a septal myectomy for outflow obstruction at the age of 33. And again, this is just one family, but I think it's a unique example of how heterogeneous this can be within its own family. All three are, positive for the gene mutation, but have completely different phenotypic, presentations. So getting into the pathophysiology, so the presence of LVH with accompanying myofibrillar disarray and fibrosis results in some degree of diastolic dysfunction in virtually every HCM case. The diastolic dysfunction in HCM and hemodynamic derangements, including prolonged and non-uniform ventricular relaxation, loss of ventricular suction, decreased chamber compliance, and abnormal intracellular calcium uptake. And in a strong subset of patients, a large number, that you can have dynamic LVOT outflow tract obstruction, which is defined as a LVOT gradient greater than 30 millimeters of mercury. And it's a determinant of therapeutic approach to HCM. Approximately 70% of HCM patients have an LVOT obstruction at rest or with provocation. Narrowing of the LVOT from septal hypertrophy or abnormal subvalvular mitral apparatus results in turbulent flow that drags the redundant mitral valve into the LVOT, resulting in decreased forward flow and systolic anterior motion mediated MR. It's important to know that the obstruction is labile, varying with fluctuations in volume status, autonomic nervous activity, pharmacotherapy, exercise, general anesthesia, conscious sedation, recent cardioplegia, physical position, and even during the course of a single diagnostic assessment, the LVOT obstruction can change, that drastically. And always something to keep in mind, especially when echoing, doing Valsalva during echo, and things of that nature. As you well know, and as you can see from that family example I gave, the clinical presentation varies widely. Patients may be completely asymptomatic and just be identified incidentally or through genetic testing within their family. AFib is present in nearly 1 in 5, and it's accompanied by a significant risk of stroke, warranting therapeutic anticoagulation independent of risk stratification criteria. So no CHA2DS2-VASc score needed in these patients. If you have HCM and AFib, you should be on anticoagulation. Symptoms are most commonly exertional dyspnea, chest pain, fatigue, pre-syncope or syncope. You can have day-to-day variability in symptom severity, and the large differential diagnosis may result in under-recognized disease or delayed diagnosis. And dyspnea is the result of the elevated left-sided filling pressures from diastolic dysfunction, outflow tract destruction, MR, or myocardial ischemia. And then the mechanisms of the ischemia is normally due to increased demand, reduction in myocardial blood flow, either due to the LVOT obstruction or compression of the intramyocardial vasculature, or abnormal vasomotor response and/or vascular remodeling. Getting into, again, just the overall prognosis, however, with this wide variability, the large cohorts of patients with HCM, however, have demonstrated nearly normal life expectancy, with only a minority experiencing the sudden cardiac death, which, back when I was younger was a large, much more talked about, I think, thing in the HCM population. And recent data has suggested that women with HCM have worse prognosis than men, coinciding with possibly due to more obstructive physiology, more MR, or more diastolic dysfunction. So here's a great kind of flow sheet for the clinical evaluation of a patient presenting with possible HCM. This was done by Dr. Marin et al. In JACC from 2022, which is a nice overview that I think you should all have been given this info as part of like the lecture series. So when you are first suspecting HCM, personal history is, as we know, HPI is very important, but it's extremely important in diagnosing this disease, kind of getting a full family tree, seeing if there's any sudden cardiac death in the family, other family members with ICDs, etc. And then you can do a physical exam and again, the family history, as I mentioned. You're going to start everyone with an ECG and an echo and consideration of a cardiac MRI. We'll get more into the cardiac MRI in terms of risk stratification in a moment. And then if you have identification of the HCM phenotype, the LVH, you're going to try and look at, is there obstruction? If there is, that will, change your management. If there's not, you want to see if you can provoke the obstruction either with a stress echo, Valsalva, or in the less likelihood medications. Genetic testing, in my opinion, should be done for all patients who you have at least a strong consideration that they have HCM. You're going to be able to find a pathogenic sarcomere in 30% of these patients, which will allow for cascade testing of all the family members, where the family members would not need to get further imaging studies done if you're able to find a pathogenic sarcomere. And then you're going to see if it's treatable or not, depending on obstruction versus non-obstruction, which you're going to go into. And as I've harped on a few times, it is compatible with a normal life expectancy. In the rare case of patients who develop heart failure, though, there are options for them as well. And then comes down to how often should you be doing this. You're going to want to see them annually. You're going to want to echo them annually. You can consider a contrast cardiac MRI every 3 to 5 years. Stress echo is really going to be done maybe on the first visit and then individualized based on your patient's case if you're looking for ongoing obstruction. Consider a Holter monitor every 1 to 3 years and then an ECG annually. One thing to keep in mind is, would consider to still do a Holter monitor, even if a patient has an ICD. They may, obviously it's case by case, but if they have just a sub-Q ICD, or if they just have an RV lead, you're still going to want to monitor them for AFib and other supraventricular tachycardias. The contrast cardiac MRI, if you have gotten to the point where you have seen how much scar burden they have and you have gotten them an ICD, you may consider not having to do that in the future. When it comes time to determine if you're going to want to put in an ICD, this is the really biggest thing in terms of risk stratification for this patient population. What we're trying to avoid is sudden cardiac death. So in the beginning, if a patient has a history of VF, sustained VT, or cardiac arrest, an ICD is recommended easy. Unexplained syncope, apical aneurysm, or an EF of less than 50. And with that, you can kind of give a 5-year risk estimate for shared decision-making, and then an ICD would be reasonable. And then you're going to, in addition to this, get your Holter monitor, look for NSVT, look for the extensive LGE on cardiac MRI. On MRI, extensive LGE is considered anything greater than 15%. NSVT is considered greater than 3 beats at over 120 beats per minute. for less than 30 seconds, meaning it's not sustained. And if you find those things, you can put this all this information along with some echo findings into a risk calculator. You can Google the HCM, sudden cardiac death risk calculator. MD-Calc has it as well, and it allows you to determine what their 5-year risk is of sudden cardiac death, and you can have this shared decision making with your patient about if they should get an ICD placed or not. It's this risk stratification that has now allowed us to have patients live almost a normal life expectancy with this disease. In terms of managing these patients, it really comes down to a few things, being do they have obstruction or do they not? Sorry, this is very small. But first, you're going to look for obstructive physiology. If they have it, do they have symptoms or do they not? If they have symptoms, you want to avoid vasodilators and high-dose diuretics, which can worsen obstruction. And you're going to treat initially right now with beta blockers, although there's ongoing studies to determine, first-line therapy in these patients of beta blocker versus a myosin inhibitor. But given the current guidelines, you would first start with at least a beta blocker or verapamil or diltiazem. If the symptoms continue to persist, you would then initiate, you would consider a myosin inhibitor like mavacamten or disopyramide or septal reduction therapy. As we know, mavacamten is a new medication out for this, but it really has been shown to be extremely good at reducing the LVOT tract obstruction, and patients seem to be way less symptomatic when taking this. And the whole study was done seeing if they can avoid open heart surgery. And then if, however, they're still, if they're still having symptoms and they want to go for a myectomy, and you'd have to look at, are they a surgical candidate? If yes, you can go for a myectomy. If not, you can consider a septal ablation. And again, this is all for obstructive HCM, which has a different management flow pattern than non-obstructive. So here we have management of non-obstructive HCM. These patients, you're first going to look, do they have a low EF, which is designated as less than 50%, or a normal EF? If they have a low EF, the guidelines say, you would treat them with normal guideline-directed medical therapy for heart failure with reduced ejection fraction. Of course, make sure to always rule out other causes of reduced EF, including epicardial, coronary artery disease. And then you will have to, with the new addition of the cardiac myosin inhibitors, if they're on that, you need to make sure to stop it and then check to see if their ejection fraction recovers. You're also going to want to remove any of the negative inotropes, their verapamil, diltiazem, and disopyramide. And then, of course, if they have an EF less than 50%, they'd be, a strong candidate for an ICD at that time. If their EF is greater than 50%, you're going to, treat them for non-obstructive hypertrophic cardiomyopathy, which is kind of, in a way, treating them with like a HFpEF management as best you can, with really considering, if they remain significantly symptomatic, evaluation for heart transplant. You could do this with cardiopulmonary exercise testing, right heart catheterization to look for pulmonary hypertension. And, based off of their NYHA class, as it says here, if they have a left bundle, you can consider a CRT. You can evaluate them for LVAD, given the LVH of these patients and the fact that we're, speaking of patients with EFs greater than 50%, the majority of them would likely not be strong LVAD candidates. I did want to touch upon special considerations that were made when the new allocation for transplant guidelines came back out in, I believe, in 2018. And this was to give these patients with restrictive and hypertrophic cardiomyopathy who are still very sick, but may not meet the, normal, we'll call it quote unquote normal criteria you would think of for patients who need transplant. They do have exception criteria for these patients. And I think it's something important to always keep in mind. And this is why I think it's important too, that if patients continue to have heart failure symptoms, that they see a heart failure specialist and or a HCM specialist to determine should they be getting cardiopulmonary exercise stress testing, should they be getting right heart caths, to look at what their cardiac index is and what their transpulmonary gradient is, et cetera, which you can see here are some of the reasons you would have a status 2 exception. So again, I wanted to keep this on the as part of the presentation because it's something I think that's important and should be kept in mind when dealing with this patient population. One of the last things I wanted to talk about was exercise and HCM. Early on, the initial treatment in terms of, or the initial recommendations for patients with HCM was to not exercise. The fear of sudden cardiac death was so strong at the, in the very beginning that they told all these patients not to exercise. And then these patients started to develop symptoms, and not symptoms, but the side effects of living a sedentary lifestyle. That has kind of gone out of favor. And now, the current guidelines are for patients with HCM to at least have mild to moderate intensity recreational exercise. This is a class 1 recommendation. And this is, of course, just to keep for overall health, physical, the same physical activity guidelines in the general population. And for athletes with HCM, this is where I think an HCM specialist really would be best to be seeing, just in terms of seeing a large number of these. Recommended, which again is just kind of saying maybe speak to a HCM specialist if somebody's considering competitive athletics. Some 2A recommendations for exercise in HCM is that individuals who are genotype positive and phenotype negative, participation in competitive sports of any intensity is reasonable. So again, these are patients and families who the patient was found to have genetic mutation, but they have no phenotypic findings, no LVH, no heart failure symptoms, no symptoms really at all. There's nothing that says these patients can't compete in competitive sports. And then for patients who with HCM and they want to participate in vigorous recreational activities, this is reasonable, again, after a full evaluation and shared decision-making with an expert professional. Lastly, in patients with HCM, ICD placement for sole purpose of participation in competitive sports should not be performed. And as you can see, that's level 3 harm. Don't know if it's seen as much in the, I'm sure it's seen some, but I think you'd see this maybe even more in the pediatric population where you have parents very nervous about their kids playing and looking to try and see if they can have the insurance policy of an ICD. However, that is, again, not recommended. And then for patients with HCM, universal restriction from vigorous physical activity or competitive sports is not indicated. So we don't want these people to not be exercising. Some of my take-home points. So as I was saying, it's a common genetic cardiomyopathy, but it does have a favorable prognosis in the majority of patients. The diagnosis requires in-depth history taking, family history imaging studies, and most tests being completed annually. Class 1 recommendation for genetic testing in these patients. Patients who do not have definitive reasons for ICD should discuss with their physician and can consider the 5-year risk score. Medical management of obstructive HCM has made significant strides with the implementation of cardiac myosin inhibitors with ongoing research into the medical management of non-obstructive HCM. And then lastly, in select patients with HCM and end-stage heart failure, heart transplant is still a viable option, and moderate exercise is safe and recommended for HCM patients. more vigorous exercise and competitive athletics should be discussed between the patient and an HCM expert. Uh,
Great. Well, thanks, Colby, so much for the talk. We do have a question for you in the chat. Um, the question is, how would you go about managing family members of patients with hypertrophic cardiomyopathy when those family members test positive for the pathogenic gene mutation?
Yeah, so if they test positive, then they should be seeing a cardiologist, of course, and then they should be screened. You should follow the screening process of HCM patients with the, annual ECG, and then you should be getting at least an echo every 3 to 5 years in those patients. So annual ECG and echo every 3 to 5 years. And you should do that even in as a screening for patients who do not test positive for a genetic mutation. So if you have a patient with HCM who doesn't test positive for a gene mutation, their family should still be screened every 3 to 5 years. And then I did see Omar message that in April, yes, Odyssey HCM showed no benefit from mavacamten and non-obstructive. I think, I kind of think you can kind of put them one way, right? HCM non-obstructive is kind of like your HFpEFs, and your obstructive is like your HFrEFs, where it's like all these medicines that work for HFrEF, and now you have all this medicines that's working so well for obstruction, but is not, being as well. It's not having the same benefit in non-obstructive HCM, unfortunately. But those studies are ongoing, and we're hopefully going to see maybe something in the future that works.
Question, Colby. How would you think about the cutoff in regards to making the diagnosis at 1.5 centimeters? Should there be, do you think, variable cutoffs based upon, body surface area, based upon gender? In my practice, I've had patients, women that seem to have hypertrophic cardiomyopathy, but their, septal thickness or wherever their thickest wall is just shy of 1.5 centimeters. What do you think about managing those types of people, or should we change our diagnostic criteria possibly for some of these other considerations?
Yeah, for patients and families who have a genetic mutation, going to as low as 1.3 centimeters would be positive for HCM. I've also been, I've been studying this a lot, and one of the world's top myectomy surgeons has said he's had patients with HCM with 1.3 centimeter septums requiring myectomy because of the obstruction, even at 1.3 centimeters. So I do think 1.3 seems to be a number that keeps coming up as a possible, but that's in the right clinical context. I think whether that's a strong family history, a positive genetic test, significant scar burden, maybe on a cardiac MRI in that area, or a large scar burden overall of greater than 15%. I don't think there's a definitive answer, but it's from what I'm seeing, it does sound like going as low as 1.3 centimeters is worth it in the right clinical context.
Any other questions from the group? All right, well, we are at the top of the hour, so Colby, thanks so much for putting this together, and best of luck to you moving forward in your career as you approach graduation. I'm really grateful for your effort and all your help this year.
Thank you. Appreciate it.